Hi, everyone. We're going to get started in 2 minutes. Thank you, everybody, for joining. We will get started promptly at noon.
Dana, can you confirm that you can see the presentation in non-presenter view? Okay, great, thank you.
Good afternoon and welcome to today's Colonization Screening one-on-one webinar. My name is Jonathan Dinkins and I'll be the Zoom support on the call today. Before we get started, I just want a few housekeeping items. First, the recording from today will be available online at a later date. Please do not unmute yourself. Next, if you're having any technical difficulties, please send an email to me at qzv3@cdc.gov. Now, I'll go ahead and turn it over to our first speaker. Ms. Soda, over to you.
Actually, it's going to be me starting things off. Hi, everybody. Thanks so much for joining today. My name is Elizabeth Vaith, and I'm the Antibiotic Resistance Epidemiology Program Administrator here at the Maryland Department of Health. On behalf of my colleagues here at MDH, I'd like to welcome you to today's webinar, which is entitled Colonization Screening 101. Hopefully, many of you were able to join our introductory webinar in September that provided a great foundation on why we are concerned about Candida auris and other multi-drug-resistant organisms in the region, and some of the ways that we can all work together to prevent their spread in healthcare settings. And if you were not able to join that one, it was recorded, so please feel free to reach out to us for the link so that you can view it at another time. Today's webinar is going to delve into the basics of what we call colonization screening. Dr. Elizabeth Soda from the CDC will give us some information on what colonization screening is, why we do it and when we do it, and how to interpret the results. And then Dr. Joe Sexton from CDC's Mycotics Laboratory and Lior Klein from the Maryland Department of Health Laboratories Administration will be getting into the nitty-gritty of how colonization screening works and the logistics of completing a screening. So at this time, I'm going to pass the mic to Jackie Rubin with DC Health to introduce herself. Jackie?
Thank you, Elizabeth. My name is Jackie Rubin. I'm an HAI epidemiologist with the DC Department of Health. Thank you all for joining us again today. As Elizabeth said, we're grateful that you have continued to provide your support and participation in how we can work together as a region to address the MDROs. And this session, we also have with us today our colleagues from Massachusetts. And I'd like to pass it over to those folks, Katie, to introduce themselves. We're grateful to have them on the call as well.
Hi, everyone. This is Jessica Leaf, the Antibiotic Resistance Coordinator for the Massachusetts Department of Public Health. And also on is Katie Riley, the Nurse Advisor for the Healthcare Associated Infections Team at MADPH. Massachusetts is experiencing an increase in Candida auris cases, as well as increasing spread of other multi-drug-resistant organisms. We think these educational resources will be beneficial to Massachusetts facilities, and we want to thank CDC and the Mid-Atlantic states for letting us join this collaborative effort. So next, I'll pass it off to Shayna from Virginia.
Thanks, Jessica. Happy to have you. My name is Shayna Bernard. I'm the Antimicrobial Resistance Coordinator from the Virginia Department of Health. And I just want to echo what my fellow colleagues from the other jurisdictions have said. We're very happy to have everyone here. We have a great topic today on colonization screening, and I have the pleasure to introduce our three speakers. So first, we have Dr. Elizabeth Soda, who is an infectious diseases physician who started her career in public health as a hospital epidemiologist before joining the CDC. Since joining the CDC, she worked with the Illinois Department of Public Health to help their response to multidrug-resistant organisms before moving to the antimicrobial resistance team with CDC's Division of Healthcare Quality Promotion in Atlanta. Our next speaker is Dr. Joe Sexton, who is formally trained with a PhD in microbiology and is the current acting laboratory team lead for the mycotic diseases branch at CDC. In addition to supporting outbreak investigations, surveillance activities, and reference work, Joe's primary focus is advancing capacity to detect and control Candida auris, an emerging and highly transmissible fungal pathogen. This includes building laboratory capacity through the AR Lab network, leading studies to better understand transmission, and evaluating environmental control methods such as disinfectants to help build public health guidance around the best available science. And lastly, we have Leora Klein. Ms. Klein has served as Lab Epidemiology Coordinator for Maryland's Public Health Lab AR Lab Network program since 2018, where she manages program operations, coordinates specimen submissions, and provides regional epi consultations for the Mid-Atlantic region jurisdictions of the AR Lab Network. Prior to joining MDPHL, she worked in multiple infectious disease areas, including mosquito-borne illness, key populations at risk for HIV, and domestic reproductive and sexual health programming. Ms. Klein holds an MSPH from the Johns Hopkins University Bloomberg School of Public Health. And now I will turn it over to Dr. Elizabeth Soda.
Thank you, Shana. All right, everyone. Thank you and welcome back. Like last time, I'm going to go ahead and turn off my video so that my bandwidth tries not to mess this up too badly. I'm going to go ahead and do that right now. But again, thank you so much for joining us for the second talk in our series of webinars about combating multidrug-resistant organisms, or MDROs. So we won't be reviewing all the concepts already covered in webinar 1. So please refer back to those slides or to that recording if you don't remember, and please reach out to your health departments if you don't have these materials. In addition, I am very happy to say that we do have continuing education available for this talk. Please refer back to the webinar flyer that you were sent regarding registration for more complete details. All right, so none of our speakers have anything to disclose. Here are our list of objectives. So, as you may remember from the first webinar, we discussed battling the spread of MDROs in 3 steps. 1, identifying as many people as possible who are infected or colonized with the MDRO. 2, having good baseline infection control and using the recommended practices for people with MDROs in your facilities. And 3, communicating to other facilities about people with known MDROs at time of transfer. In today's webinar, we will be focused on step 1, and particularly about the identification of those individuals who are colonized with MDROs in your region. And as an additional reminder, while the term MDRO is an umbrella term that includes a number of pathogens, today we're specifically speaking about colonization screening for Candida auris and the carbapenem-resistant Enterobacterales, Pseudomonas aeruginosus, and Acinetobacter baumannii. And remember, if any of these organisms are identified as producing a carbapenemase enzyme, such as KPC or NDM, we also refer to them as a carbapenemase-producing organism, or a CPO. I'm next going to pass it over to Joe, who will review some of the basic MDRO colonization principles. Joe?
Thanks, Elizabeth. So just a couple broad points about colonization. So colonization means that a person is carrying an MDRO in or on them, but does not have symptoms of an infection. And it's still important to detect colonized individuals for 2 important reasons. First, some colonized people will go on to develop infections, and 2, they can be a source of spread of MDROs to other people in healthcare settings. And we often like to show an iceberg analogy where when you have individuals infected with an MDRO, it's usually just the tip of an iceberg. There's usually a larger group of individuals that are colonized. Next slide, please. So how do colonized individuals and MDRO transmission occur in healthcare facilities? A couple different ways. One is through contact, healthcare personnel working with multiple patients, and also through the contamination of mobile equipment. So these are things that core IPC practices can help disrupt. Good hand hygiene, PPE, and environmental disinfection can play a big role disrupting transmission. So just to elaborate a little bit more, especially with the environmental contamination component, in addition to mobile equipment, individuals colonized with MDROs can lead to broader environmental contamination. And some MDROs like Candida auris can persist for weeks, and that clearly increases potential for transmission to other individuals. So that just, again, reiterates the importance of adequate cleaning and disinfection of the healthcare environment. It's really critical to controlling the spread of MDROs. And I want to highlight the importance of using an appropriate disinfectant. Not all disinfectants work for all MDROs, so you should be familiar with the label claims. You should be using an EPA registered product, and make sure that the label claim supports disinfecting the MDRO you're working with. Just as an example, list P is a specific list of disinfectants that work for Candida auris. So a lot has happened in the last couple of years with list P. Just a couple of years ago, there were no products on list P, leaving us in a spot with interim guidance for sporicidal products. But at this point, there's over 25 products known to be effective and approved by the EPA for C. auris. So you can reference that list for Candida auris. A couple principles about how colonization works. I think it's important to realize that MDROs can be found in many different body sites, and different MDROs colonize different body sites. Just to give you an example, we've learned over the last couple of years that Candida auris can colonize a wide range of body sites. Axilla, groin, nares, hands, toes, and a lot of other skin sites in between. CRE tends to preferentially colonize the gastrointestinal tract. So then when it comes to how are we going to screen for colonization, screening, you don't necessarily have to sample every single body site that could potentially be colonized. We need to pick something that's going to be useful for reliable detection. So for Candida auris, the recommendation is bilateral axilla and groin swab. And for CRE, that's a rectal swab. Another important detail to be aware of is clearly there's no boundaries preventing someone from being colonized with multiple MDROs. And we actually see that quite frequently there. And this is a map showing the distribution of multiple MDROs in a ventilated skilled nursing facility, and the different color combinations show different permutations of co-colonization. Another really important thing to realize is colonization can be long-term. This is some data, again, from Chicago at a ventilated skilled nursing facility, looking at colonization over time. And this is essentially just showing that we see colonization last for long periods of time and even years. And sometimes in follow-up screenings, you may see a patient go negative and positive. And there's a couple different things that could explain that, but I think the bigger picture is once colonized, it can often be long-term. So it's really important to maintain those core IPC practices. Again, just reiterating why it's important to detect colonized patients. They can go on to develop infections. Just some numbers behind that. Candida auris, for example, we've learned that 5 to 10% of patients colonized with Candida auris go on to develop invasive infections, and that mortality can be over 45% for those within the first 30 days. Thank you, guys.
So we're now going to take a closer look at colonization screening. Before we start, I want to first acknowledge that your health departments are really the real experts in colonization screening for your area. They're very knowledgeable, very supportive, and all very nice. So please talk to them if you have questions or concerns about screening. Other disclaimer is that we will be talking a lot about colonization screening today, but it's very important to remember that only a combination of colonization screening and infection control will decrease MDRO transmission in a facility and throughout a region. So what do we mean by colonization screening in the first place? It is defined as using a swab to sample different body sites to determine if that person has the MDRO that you're interested in finding. So again, they're colonized, but they're not infected. There are several different colonization strategies to include point prevalence surveys, both response-based and proactive, as well as emission and discharge screening. We'll be reviewing each of these different types using a case-based format and hopefully a Zoom polling option if I can get it to work. So let's dive in. A point prevalence survey, or PPS, is when colonization screening is performed on a group of people at the same time to determine how many of them are colonized. Despite the use of the term survey, this is not research or the result of some regulatory action, but is an important type of public health surveillance. Specifically, a response-based PPS is conducted in response to the new identification of a person or multiple people with an MDRO in your facility in order to see if you can find colonized people you didn't know about before. So using this knowledge, let's begin with case number 1. This is an 81-year-old man who is a long-term resident of a ventilator unit in a ventilator-capable skilled nursing facility, which I abbreviate as a VSNF, for the last 3 years. Recently, he had a urine culture with carbapenem-resistant Klebsiella pneumoniae with NDM enzyme production. This is actually the first NDM ever detected in this facility, and NDM is not common in the region the healthcare facility is located in. He had not been on contact or enhanced barrier precautions, or EBP, prior, but is now in a private room on EBP. He had had 3 roommates prior to moving rooms, and in addition, there are 20 additional residents located on the ventilator unit. So here's our first poll question. I'm gonna try to launch it. I'm hoping you guys can see it. And pick the response that you believe is most correct. So the question is, what type of colonization screening will the health department most likely recommend initially? A, is it a response-based PPS for CPOs but limited to only roommates and people adjacent to his? B, is it a response-based PPS for CPOs with screening of all residents on the ventilator unit? C, is it a proactive PPS? Or D, is it discharge screening? Let's go ahead and give everyone a second. To put in their answers. And I'm not sure if it worked. Can anybody confirm if that worked? Don't think it did.
Elizabeth, I think I see folks putting in their answers into the Q&A.
Okay, great. Sorry, guys. And Jonathan, if you can find any way to, I'll try relaunching the poll.
Say that again. You said end it.
All right, let me end it. I am not seeing anything. So maybe we'll just go with the Q&A. Sorry, guys. Might try for the next question. Okay. So the answer is B, a response-based PPS. All right, so we'll talk about why. So there are multiple factors that your health department considers when recommending the use of a response-based PPS, even after just identifying one person with the Mdro. One factor is how common the Mdro is in your region. The less common the Mdro is, the better a response-based PPS can limit spread within your facility and your region, while the problem is still a small spark instead of a raging forest fire. Your health department may also consider which unit the patient or resident with the Mdro is or was located on. For instance, response-based PPSs are very important for units that care for many patients or residents who are at high risk of becoming colonized, so intensive care units or other units with people on ventilators. However, there may be units even beyond these that would require a response PPS, and it all really depends upon the circumstances. And last, your health department will consider both your use and your adherence to infection control actions such as contact precautions or enhanced barrier precautions, hand hygiene, and environmental cleaning and disinfection. But what about who you should screen? Sometimes you can start by initially screening a select or targeted group of people, such as those at highest risk for Mdro colonization on a unit, to include roommates or those who may have shared bathrooms. However, transmission often occurs well beyond roommates, so it should also include other people at high risk, like those who are ventilated or bedbound. However, oftentimes broader screening, such as an entire unit or even a facility, is needed. As in our case example, almost all people on a ventilator unit are considered at high risk for Mdro colonization. Or if you're determining who is at high risk is just too time consuming and will delay the PPS, or if the initial targeted screening reveals more people with the Mdro, then broader screening is also warranted. One common question we get is how to prepare patients and residents for a PPS and minimize screening refusals. One of the most important factors is having a healthcare personnel who can clearly and plainly communicate about Mdros and colonization screening, to include the need to collect rectal and groin swabs. Not every healthcare personnel may feel comfortable or knowledgeable enough on these topics, and finding those who are may significantly improve acceptance rates. CDC has multiple resources to help facilities educate their personnel and patients or residents on these topics, some of which are listed in this slide. In addition, especially when your facility is new to conducting screening, using a script can sometimes help with this process. Here's an example of such a script crafted by CDC. However, your health department and even your neighboring facilities may have additional thoughts on resources or how to best do this. And remember, having the ability to communicate this information in the languages your patients or resident populations speak is critical. In addition, colonization screening does not require written consent since it is part of a public health activity. You can find more information on the concept of patient consent versus assent for colonization screening later in our FAQ section. All right, so case one continues. Our VSNIF conducted a response-based PPS of the whole ventilator unit, and the PPS identified 5 residents colonized with an NDM-producing organism. In addition, there's a Candida auris outbreak in a neighboring facility which frequently transfers residents to them. All right, so I'm gonna try this poll again. And see what we get. Okay, so this is question number 2. Which of the following recommendations would the health department likely make? A, allow the health department to assist with an infection control assessment. B, conduct another response-based PPS in several weeks. C, to look for Candida auris as well if a future PPS occurs. Or D, all of the above. I think it may have sort of worked last time.
And Elizabeth, we're hearing that maybe they can't hit submit until they answer all of the questions, but I'm seeing.
Oh, bummer.
So it doesn't look like we can go stepwise, just as an FYI.
Okay.
Unless somebody else found a
that
different
must be
way.
the issue. Best laid plans. Looks like we might be getting some folks maybe going through all of them to do it. Well, thank you all for trying. So I'll go ahead and end the poll. And for our small sampling, I think most people answered all of the above. And that's the answer I would also probably include. So I'll talk a little bit about that. Several actions should be taken if you identify colonized patients or residents on the PBS. First, stay along with any family or guardians should be notified. Second, infection control is key. So for anyone with the Mdro, the recommended IPC actions should be taken immediately. If you're a nursing home, you should work with your health department to determine if implementing enhanced barrier precautions on the affected unit for all individuals with Mdro risk factors should be taken. In addition, all facilities should work with their health departments to gain more information about these individuals, so you and the health department can determine the likelihood of whether transmission or spread of the Mdro is occurring within the facility, something we may refer to as a cluster or an outbreak. And while no one likes to hear these words, I'd also encourage you to try to change your perspective on that matter as well. There are many benefits to identifying colonized individuals, even as part of an outbreak, to include direct benefit to them. For instance, their clinicians may be better able to tailor empiric antimicrobial choices with this knowledge if they do ever become sick. In addition, this knowledge can help your facility reduce the size of the outbreak, but also limiting further spread throughout the region. In addition, identifying an outbreak means you'll have to work on infection control improvements, which is always a good thing. And this is something you should consider doing even if there is no transmission identified to help prevent outbreaks in the future. You'll also likely be asked to perform more PPSs in the future, especially after infection control improvements are made. These follow-up PPSs may serve as a marker that spread of the Mdro within your facility has slowed or stopped. And last, seriously consider expanding your PPS to look for other Mdros if suggested by your health department, as they have a sense of what additional threats your facility may be facing. So our facility decided to do another response-based PPS to look for both those CPOs such as NEM and Candida auris on their vent unit 2 weeks later, after they've made some improvements in hand hygiene. But their PPS identified 2 new residents despite this with the NDM, but no one with Candida auris was identified. So question 3 is, what should your facility do next? A, give up. B, go to the health department. C, continue to evaluate and correct the infection control gaps. Or D, blame the facility up the street. If our poll does not work, I'm just going to go ahead. You guys think of an answer you think it'd be. Hopefully it won't be go to the health department. And it's C, continue to evaluate your infection control gaps. So as I mentioned before, life is all about perspective. Finding more colonized people on additional PPSs suggests an ongoing outbreak, and that's hard because no healthcare facility wants to bring harm to their patients or residents or those within their transfer networks. And most of us do our best under those circumstances and with the resources we've been given. But sometimes, despite our efforts, transmission happens and happens and happens. I have been there, and I know this can cause frustration, anxiety, anger, blame, and I've definitely had some few choice words. But what can you do if this happens? First, don't give up. Many times, the systematic infection control practice problems that led to the outbreak did not develop overnight, so fixing them can take time. However, dedicating that time and resources to making long-lasting infection control improvements are always worth your effort. Second, don't get too focused on the PPS results alone, as slowing or stopping the outbreak, as I mentioned, can take time. So find other measures of success to mark your improvements, such as an increase in hand hygiene audits, or an improved process to ensure shared equipment is cleaned and disinfected. Third, don't become too laser focused on where you think someone acquired the Mdro, because in the end, when the patients or residents are in your facility, it's going to ultimately be up to you to prevent any further transmission down the road. And last, don't forget the people behind the diagnosis. I just want to take a moment to acknowledge all of the patients and residents each of us have known and who have been affected by these Mdros. And let's remember them as we continue to work together to prevent these Mdros from affecting more of our patients and residents today and in the future. On to our next case. We have an infection preventionist at a long-term acute care hospital, or LTAC. She was reading about a health department alert regarding Candida auris in the area. She already started assessing and improving her current infection control practices, but she wants to do more. Our next question is, which of the following colonization screening activities could she suggest to her administrator? A, proactive PPS, B, discharge screening, C, emission screening, D, A and C, which are proactive and emission screening, or E, all of the above. I'll give you a second to think about what you would pick. And the answer is D, both proactive PPSs and emission screening. So like in our first case, where PPS was used in response to identifying someone with an Mdro, a proactive PPS is conducted at a facility regardless, and possibly prior to the identification of someone with the Mdro. The proactive PPS is likely best utilized at facilities at highest risk for transmission, usually based upon patient acuity and length of stay. So proactive PPSs can be particularly useful tools for VSNFs and LTACs. The best part of the proactive PPS is instead of waiting for the Mdro to find you, it allows your facility to take control and seek out the Mdro first. A win for your patients and residents, a win for your facility, and a win for all the other healthcare facilities in your region. Sometimes these proactive PPSs can occur as needed, or other times they can be considered part of your regularly scheduled infection control practices, such as every 4 to 6 months, especially for VSNFs and LTACs who will continually face threats from Mdros. And as we've discussed in the past, it's better to screen for more than one Mdro based upon the threats you're facing in your region. So maybe you're going to want to look for both Canada, auris, and CPOs. But one factor that often stops facilities from utilizing it is the fear of discovering the Mdro inside their buildings. So yes, let's acknowledge that you may find the Mdro if you look. And yes, this may cause you angst and will likely require more PPSs and will definitely require increased focus on infection control. But you must remember that knowing on your own terms is better than not knowing, because if the Mdro is in your facility, it will rear its ugly head someday. So it's up to you to decide how and when you want to find out about it. But you may also not find the Mdro, which means that you can continue to strive to assess and implement solid infection control prevention measures to prevent transmission if and when you do find it. Another type of colonization screening is emission screening, which attempts to detect the Mdro upon someone's admission to a unit or facility, and should be considered again for more than one type of Mdro depending upon your threat. While any facility can utilize emission screening, we believe it may benefit certain facility types under certain types of circumstances. For VSNFs and LTACs, emission screening is best initiated along with regularly scheduled proactive PPSs because the facility with only a few people with the Mdro will benefit the most from emission screening. This exception is a facility with many people who already have the Mdro, but currently with very good infection control practices. And this is especially true if you have a dedicated unit to care for people with Mdros, as the emission screening would help you better ensure patient or resident placement. For acute care hospitals, the ability to detect more individuals at admission will come as the overall amount of the Mdros increase in your region, and those who frequently share patients with LTACs and VSNFs may benefit the most. In order to implement screening well, it will require you to develop a plan that makes sense for your facility. Two of the biggest factors to consider while developing your plan is who you plan to screen on admission and how you'll identify them. The who question really boils down to available laboratory resources and how you can best maximize the odds of identification with the benefits of that identification among those you screen. To highlight this idea, I've given several examples of how some facilities throughout the country have chosen to use emission screening on this slide and this slide for you to review afterwards. In addition, on a future webinar, we plan to highlight a facility that successfully implemented an emission screening program with the help of their electronic health record. So we really hope you'll join us for that one. All right, so we've got our last case. And this is an intensive care unit in an acute care hospital that is experiencing an outbreak of highly drug-resistant NDM E. coli. We've had 3 rounds of response-based PPS that continue to find patients. They have multiple critical gaps in their infection control with low hand hygiene rates, staff that are not correctly using gowns, and they're not cleaning and disinfecting their shared patient equipment. So question 5 is, what steps can this facility take to limit transmission to other healthcare facilities that transfer? Would it be discharge screening? Would it be communicating? Would it be working on their infection control gaps, or would it be all of the above? And the answer is all of the above. As we discussed in the last webinar, healthcare facilities within a region are very much connected to one another through patient and resident sharing, making it also easy to share the Mdros. So what one facility does or does not do can have an impact on many people. But stopping the spread of MDROs is not just about one facility limiting their transmission, but it's also taking measures to protect all the people in all the facilities in the region, such as communicating. Regardless of whether your facility is experiencing an outbreak or not, communication at every transition in care is important for patient safety, to include someone's MDRO status. The transferring facility should ensure that the accepting facility is aware at or ideally prior to transfer. This should include not only the person's MDRO status, but also the recommended infection control practices. Here's an effective way of doing this and implement it consistently for every transfer. For instance, perhaps both through written and verbal communication. The accepting facility should ensure their infection preventionist is aware of the person's status to implement recommended infection control practices immediately upon arrival. And don't forget to communicate with your health departments based upon their reporting expectations of someone's MDRO status at first identification or upon transfer. And this is true even if your laboratory is not using public health resources for colonization screening. If you're not sure what these expectations are, please reach out to them. And last, we know this can be a very complex topic and one that we are planning on covering in future webinars. I know I've said this many times already, but regardless of whether you are or are not experiencing an outbreak, good infection control practices is key. Again, all of these topics will be covered in more detail during future webinars. And the last type of colonization screening we want to talk about today is trying to help protect your region through discharge screening. And this is especially useful when a unit or whole facility is experiencing an outbreak, or if your facility in general just cares for many people with the MDRO, even if you're not in a current outbreak. The successful implementation of discharge screening requires a well-developed implementation plan. For instance, can your lab help perform it? If not, are there public health resources? And how long will it take to get a result? You also have to decide when you would actually screen. Predicting exact discharge dates can be challenging and sometimes completely unplanned. In this situation, it may be best to screen as part of the discharge process. In planned discharges, you could try to screen a day or two prior to discharge in order to have the results prior to transfer. In addition to will you screen, consider focusing your screening on those people discharging from an outbreak unit or facility to places at highest risk for MDRO transmission, such to a VSNF or an LTAC, or from an ICU with an outbreak onto an oncology unit. And don't forget that communication is key, both with your health department and the accepting facility or unit. If the discharge screening results are not back prior to discharge, the accepting facility or unit must be aware of these pending results. If the transferring unit is experiencing an outbreak, then ideally the accepting unit or facility will use the recommended infection control practices, such as contact precautions or EBP, in nursing homes until the testing results are available. And once the results are available, it should be communicated back to the accepting facility or unit. However, pending discharge screening results should not delay someone's transfer once they're medically ready for transfer, and nor should they prevent someone's acceptance to another facility or unit. The next several slides are really here for you to refer back to as needed about the different types of colonization screening that we just talked about. And for the sake of time, I'm not going to spend too much time in review, but each slide highlights the different types of colonization screening and what type of healthcare facilities the screening types may best apply to for response-based PPSs, for proactive PPSs, for emission screening, and for discharge screening. All right, I'm going to next pass it back over to Joe to talk a little bit about environmental sampling.
Thank you. So this will be really quick, but I do want to address a couple points about environmental sampling. We get a lot of questions and interest in environmental sampling. So I want to highlight when environmental sampling can be helpful. The key is I want to emphasize that it's a narrow context and is hopefully a decision you'd make in communication with your local public health. But essentially, it can be helpful when all other efforts to stop transmission have been well implemented, but you continue to see transmission. And you should really have clear questions that you hope to answer rather than a fishing expedition. And again, just highlighting communicating with your local public health jurisdiction before diving into environmental sampling. And the reason that we emphasize the value of communicating with your local public health department before doing environmental sampling is because there are some important limitations. In particular, you can't use environmental sampling to confirm that an MDRO is absent. And what we really tell people is if you've got someone colonized, it's really presumptive that the environment is likely contaminated. So that result really shouldn't change any of your practices. If you know that they're colonized, you should already be implementing the appropriate IPC. So a lot of times people are interested in using it as a cleaning assessment. Again, trying to confirm that it's gone. There's reasons why it's not good for that purpose. And there's actually better alternatives for assessing the thoroughness of cleaning, like fluorescent markers or ATP bioluminescent markers as well. Thanks.
Thanks, Joe. I'm going to turn it over to Eeyore now to talk a little bit about the colonization screening nuts and bolts.
Okay, hi everyone. So now that you've heard all about the reasons why we want to do colonization and all of the different strategies, let's talk about how we actually get it done. So how do healthcare facilities access MDRO colonization screening? You go through your health department. So unless you have a prior arrangement with the health department and the performing lab to do ongoing admission or discharge screening, you should be contacting your state jurisdictional health department's HAI group to request testing. This testing is still on a request basis only through the AR lab network. And so who your performing lab is depends on where you live. So if you are in the Mid-Atlantic region, so Pennsylvania through South Carolina, then you're going to be requesting testing through us at the Maryland Public Health Lab because we are your regional laboratory. If you are located in Maine through New Jersey, then you will be going through the Wadsworth Center. And in the coming years, as some additional public health labs may be bringing on colonization screening, that may change, but that's why it's so important to first and foremost go through your state jurisdictional HAI group to request testing. Next slide, please. So how do health departments access colonization screening? So first off, a health department will assess a facility and what their needs are, and then develop a plan for screening. They'll send this request to the public health lab with the plan for screening, including epi details and the plan scope. The public health lab will review the screening and review the plan for screening, and we may suggest some adjustments for timing, scope, based on our lab capacity, and we're frequently in consultation with subject matter experts when we make this, when we do this consultation. So once we've done that, the screening plan will either be approved or rejected. Most of the time they are approved, and generally it is, if a request is rejected, it's just that it is not really, colonization screening isn't the best way to answer the question that you are bringing up, but most of the time it is. So we will ship collection kits to the facility, and if you're getting tested, if your swabs are getting tested at Maryland specifically, then we'll provision lab web portal accounts as you need in order to order tests. Next slide, please. So when we ship colonization screening kits, we have a kit specifically for CPO colonization screening and a kit for auris colonization screening. And I want to just take a minute to run through them so that you have an idea and facilities have an idea as to what you're actually going to see. So in a CPO colonization screening kit, we have a biohazard bag, a Copan Transsystem sterile transport swab, and we'll look at those swabs in more detail in a moment. You'll have parafilm, absorbent paper, and a specimen collection cheat sheet. Next slide, please. This is just the specimen collection cheat sheet in a little bit more detail so you know that what you're going to receive. It gives instructions as to how to collect the specimen, and for rectal swabs specifically, we have a guide as to what, how much specimen is too much specimen, since that can cause an invalid result. Next slide, please. So looking at the swabs for CPO colonization screening, these are rectal swabs only, and they are only made by Copan, and it is only the Copan Transsystem sterile transport swabs. These swabs are attached to the red top of the tube, and it is a double swab with a small sponge at the bottom. The test that we use for CPO colonization screening is the Cephia Gene Expert, which is an FDA-approved test. So we cannot accept any other swabs other than this one in order for us to give you results. So you have to use these swabs. Next slide, please. Now, what is in a C. auris colonization screening kit? We have, like the CPO kit, we have a biohazard bag, the e-swab, we have parafilm square, absorbent paper, and a specimen collection cheat sheet, but now we also have an e-swab, which is a different type of swab. Moving on to the next slide, please. You'll see the cheat sheet. So we give you instructions on how to collect the specimen, where you should be swabbing, and how to package it, and make sure that you are where you place the lab requisition. Next slide, please. So I want to just spend a moment clarifying the types of swabs that you may see for e-swab. So C. auris colonization screening is by and large an axilla groin specimen, and due to the use of e-swabs during the COVID-19 pandemic for COVID testing, supply chain challenges have been persistent. And so many public health labs doing C. auris colonization screening have had to use e-swabs by many different manufacturers. And so that's why you won't always see the same type of e-swab. So sometimes it usually has a white top, sometimes it has a blue top or a green top or a purple top. And it's a single swab, flocked swab with a breakpoint in the middle. And there is a small amount of liquid in the bottom of the tube. And it is very important that that liquid stays in the tube. So next slide, please. So some labeling requirements for our specimens. All specimens, whether it's for C. auris or CPO colonization screening, needs to be labeled with the following. We need name, date of birth, and collection date. If your tube is unlabeled, it will be rejected. I do not care if it comes with a lab slip, it will be rejected. That is clear regulations. We have absolutely no latitude with that. We wish we could, but it is absolutely not within our regulatory capacity to accept unlabeled swabs. So make sure that they are labeled, and always talk to your public health lab about specimen criteria, acceptability criteria prior to screening, because they may change over time. But in the Mid-Atlantic region, the identifiers that you put on a tube have to match an accompanying lab slip. In the Northeast region, you'll find that these identifiers have to match the line list that you give to the health department, because they give you a manifest which you ship with the specimens. Next slide, please. Looking into Maryland's requisition requirements specifically, we require requisitions to be generated in our lab web portal. Either you will generate them or the health department will do so and send them to you. Once generated in the lab web portal, they need to be printed and placed in the outer pocket of each individual biohazard bag. Do not place the requisition in the main compartment with the sample. We need it in the outer pocket, and it needs to be printed because the barcode that you see circled is what we use to scan the information into the system. Next slide, please. So some common reasons for specimen rejection. The biggest one, as I've already mentioned, is an unlabeled tube, but sometimes the e-swabs will specifically, they may leak in transit if they're not closed properly. And also for e-swabs, if the swab is missing from the tube, so sometimes people will swab the patient and then just swirl the swab in the liquid and then discard the swab. We need the swab in the tube. And then sometimes people will pour the liquid out of the tube prior to submitting the swab. We do need that liquid to be in the tube. So swab and liquid have to be there. And for rectal swabs, the biggest cause for rejection, or it's really an invalid result, is if there is too much sample on the swab, because that causes an issue with the instrument that we have to run the specimen on. Next slide, please. So for some packing and shipping requirements, these are specific to regional labs. Different labs always have, may have different requirements, but specimens can be shipped at room temperature, and they must be tested within 5 days of specimen collection. So if you collect on a Monday, we need to have that specimen and test it before Friday. If you send it the next week, we will have to reject it. And they must be shipped in compliance with Category B biohazard shipping regulations. We'll provide you with a lot of the materials that you need in order to be Cat B compliant, but it's every facility's responsibility to make sure that you're shipping correctly. So the main basics, and we have pictures in the additional slides that will be shared after this presentation. But the main criteria are you need a sealed primary container, which is a tightly closed and parafilm specimen tube. That's why we give you parafilm. And a sealed secondary container with absorbent material. So a closed biohazard bag with the specimen tube and absorbent paper in it meets that requirement. And then a rigid outer container with a UN 3373 label. So that is your shipping box. You cannot send specimens in an envelope. They have to be in a box. Next slide. And actually, I think that's it for me. We can move on to Q&A.
Yeah, so before we start on the Q&A, I know we only have about 10 minutes left. I just wanted to show you some of the additional slides and resources that we do have. So we do list everyone's contact if you want to contact your health department. As I mentioned, this one does have CE, so please see your registration flyer. And the recording and slides are going to be posted to this link, posted through the Virginia Department of Public Health. In addition, CE will be available on demand for the recording. So if any of your colleagues really wanted to listen and didn't get a chance today, they can do so and actually still receive CE in the future. And the information on that is also on the website. Our next webinar, we're going to try to target for February of next year. It's going to be hopefully our CDC long-term care team presenting on enhanced barrier precautions. And this is probably of intense interest to some of the nursing homes out there in particular. So, you know, we really hope that you'll join us and we'll give you a better sense of dates as we get closer. Again, just want to highlight that we still, you know, have a number of other topics we hope to pursue, a little bit more about infection control. There have been some folks who want us to talk about Mdros in water. I think that's a really good topic. I'm hoping to do a little bit of the ABCs of CPOs, because they can be super confusing with all the alphabet soup out there. I also want to talk about communication and hoping to host an open forum so we can get a better sense from you all, you know, how we can go about improving this. And let us know if there are other topics that you want to hear about. We really are hoping to cover what y'all want, so just let us know. In addition, we do have some additional resources and links here. These are the packaging considerations that Lior mentioned. And then before I get to questions real fast, I do want to say that we have an FAQ section that these cover some of the frequently asked questions we get. And so, you know, peruse through these too if you have any questions as well. And I will turn it back over to Katie or my other folks in the health departments to help start the Q&A.
Great, thanks everyone. This was awesome information. There's definitely been some questions that have come in during the webinar, but just a reminder, please enter your question into the Q&A box and we'll try to address them in the time we have left. Speaking of the slides, can we flip back to the contact your health department slide? Someone was asking for that, so maybe leave that up while we do the question and answers. And then let's see, I did see one question about do facilities have to pay for these tests?
So I can answer that. I answered it live, but I answered it in the chat. But facilities, if your swabs are being tested by an AR Lab Network regional lab or CDC, it is free of charge. If you are sending specimens to a private lab to do any sort of testing, then of course you'll be charged in accordance with their policies. But if it's done by us in Maryland or New York or another state public health lab, it is free.
Great. And then another question that I think was answered live as well, but I think it's worth repeating. Someone asked, is there an optimal, for auris, is there an optimal length of time between potential exposure and positive colonization screen? Thinking about COVID testing best performed at 5 to 7 days after exposure. So is there a sweet spot for C. auris testing?
That's a great question, and I think that's something that we're still honing in and learning about. But that's a great question.
Yeah, and I think to Dr. Sexton's point, we've received this question a lot in DC, given the colonization screenings that we've been doing and trying to link exposures with potential colonization or infection status. And I'm working with the mycotics team at CDC. They've conducted some studies, where they saw transmission, from exposure to colonization within, 8 to 12 hours. But as Joe mentioned, we haven't really had the capacity to study that. And then with intermittent colonization too, I think it's just a big question that still needs to be addressed and answered that we don't have the answers to right now.
Okay, great. Someone had asked if there's a link to check the COVID positivity rate in Baltimore County. I don't know if we went over that. I guess that's COVID and not C. auris, but so maybe someone, I don't know if someone can type that into that participant.
I'm happy to.
Thank you. Another question, what are EPA approved disinfectant wipes for CPOs?
Yeah, that's a good question. And really, the best thing to do is to look at the back of your bottles to see what it covers. It should tell you on the back. I would say most routine hospital-grade disinfectants are going to get most of your CPOs. With some exceptions, for instance, Acinetobacter, you may need to double check to make sure that your label on whatever product you have has the appropriate label that it can kill it, and then assess what the kill time is for that.
Great.
And to add to that too, I think one thing that we've seen with facilities now with the new list P is really looking over that list, because there are a lot of products now. We're not just relying on bleach or whatnot, but a lot of products that will kill both Candida auris and COVID-19. And one of the, I guess, concerns that our facilities have been with implementing new cleaning products. But the other recommendation that we've been giving out is doing it facility wide too, because, as Joe mentioned, there can be spread, on equipment or on healthcare personnel's hands. So actually putting into effect a cleaning product that's effective against certain CPOs facility wide is a recommendation that I know DC has been giving.
Yeah, agreed. That's
really
a great
good point,
recommendation.
Yeah, but they definitely will find a number of products now that will get CPO, C. auris, and COVID, the C's.
And tagging on that, there's a question, what brand of wipes is approved for C. auris? So again, we would, have you look on the back of a product or check that EPA list P, which are approved products for C. auris.
You'd probably actually be surprised. A lot of what folks are using in their facilities, like the Purple Top Virex, are approved. So we're happy to send that list out. I think it's in the resources, but having you guys double check that to see if those are any of the products that you're currently using. We'll be sure to highlight that.
Great.
And this is one more quick point about disinfectants. I think it's really important also to look at the EPA registration number. Sometimes the labeling and the color of the tops of the tubes can be confusing. A lot of times companies may market similar but different products under similar labels, etc. So again, please cross-check the EPA registration number to make sure you're aware of the product that you're using and its efficacy. Over.
Okay.
I'll just add to that. Sorry, just about also making sure you're looking at your kill times or your contact times, because Oftentimes products might try to advertise their lowest kill time or contact time, but it's not really until you get into the meat of it on the back of the bottle that you may realize, oh, I actually need to go much longer for Candida auris than perhaps what's been advertised on the front of the bottle. Sorry, go ahead. Sorry about that.
No, that's okay. And I think that that's a great point. And I always like to say reinforcing with staff that, you know, the meaning of contact time, kill time, wet time, what those terms are, what they mean. It's always a great staff education idea. There's a question, when should someone request a test or do a test? Is it when one MDRO is identified?
Yeah, that's a good question and a complicated question. So I think it depends. It depends. And I think, let me see, try to highlight. Sometimes we do think that you should conduct a response-based PPS, even if you've just identified one case. Like in our case facility, they only identified one case of MDM. But you know, that's because this was a very, this was a VSNF, right? That could have had a lot of people, right, who were potentially going to could become colonized with it. In addition, MDM, as in our case, was very uncommon in this facility. So that would be yet another reason for going ahead and doing testing just after identifying that one person. And then in addition, like in our case, this gentleman hadn't been on any type of like contact or enhanced barrier precautions. So the risk of unwillingly transmitting that to somebody else was higher. So this slide sort of highlights like those points. Certainly they're not the only factors that go into whether or not you need to do a PPS based upon just a single person, but are definitely some, I think, some of the more common things that we think about when we do go into that.
All right, great. I know we haven't answered every single question. I think we got main themes. Someone is asking about kind of enhanced barrier precautions. So I would say tune in February for that next webinar. But I will turn it back to the panelists for final words and wrap up. And maybe there was a question on where to access CEU information. So maybe if someone could just speak to that as well. Thanks.
Yeah, sure. Thanks, Katie. Yeah, so for the CE, it's all that registration flyer that was sent out to you will have all that information in it. So it was whatever link that that was. If you don't have it, you can also go to the ending link where the recording will be sent. And there's information about that as well, like where you can access it. So I'm sorry, I know I'm trying to get through all the crazy. Yes, so here you can find additional information on the CE and the recordings and the slides. And I know we're a little bit over time, but again, I really, as always, want to thank you guys so much for tuning in and being engaged and asking really good questions and to listening to us and being our really amazing partners as we continue to work on this together. So thank you, and I'll turn it over to anyone else who wants to say their goodbyes.
This is Jackie from DC. So first of all, thank you to our colleagues from CDC, Dr. Joe Sexton and Elizabeth, as well as Lior from Maryland. We really appreciate your expertise in providing your time this afternoon. I'd say for if anybody has any questions that were not answered, please do reach out to your state jurisdictions. I think we're going to be compiling questions so we can create a more informative FAQ sheet that we can give out. But as Dr. Soda said, I think just thank you all for your continued participation as we work towards addressing this.
Well, I think with that, we probably can end the webinar, and we really look forward to talking to you all in February, and have a very happy holidays. Talk to you all later.